Welcome to the Pro Aging Podcast. I'm Steve Gurney, founder of Positive Aging Sourcebook. We're excited you can join us for our interactive discussions with pioneers and thought leaders on a wide variety of topics related to aging and longevity. Well, it's that time of year, again, where current Medicare beneficiaries can make changes for the 2022 plan year. In today's discussion, John Norce, founder of the Medicare Portal, answers dozens of audience questions and provides details on how you can plan and evaluate Medicare in the coming year and into the future. So let's jump into the discussion. I'm real excited that we've got John Norce, who's the founder of Medicare Portal. We had a discussion with John last year, and it was one of our most popular discussions. And I realized that we were right up on open season, and I was like, we have got to do another discussion with John. So I called him in a flurry, and we tried to schedule something right before open season, and we had a Monday. I know we normally don't do these on a Monday, but I figure if folks can't attend, we've got the recording, and we'll share that recording with everyone. So John, thanks again for being available. I know this is a busy time of year for you, but before you dive into your PowerPoint there, share with us a little bit about your background and what the Medicare Portal does, and then
Sure.
we'll dive into this topic.
Sure. Well, for the, I always seem to know some people on these Zooms, and it's nice to not see you, but to have you here and see that probably things are going well for you. For those that don't know me, my name is John Norce. I'm the founder of Medicare Portal. All we do is assist seniors with their Medicare benefits, whether they're enrolling for the first time or they're an existing beneficiary looking for assistance. I have over 3 decades of insurance experience that I applied to the success of this business. This business I've been running for 5 years. We have almost 20 people that work here. Sorry, Steve, you're
Oh yeah, just ignore that.
I'm sorry, you're fine.
I threw up a survey there to just give us a glimpse of who's in the audience today. But keep on talking, John.
No, you're fine.
Okay.
But anyway, we're solely focused on Medicare. I do have some slides here. We are based in Tyson's Corner. That's our quote headquarters. Although, like many, we work remotely. We actually cover 22 states outside of Virginia, up and down the East Coast, and obviously some states west of here. We are independent. It's important to understand that we're not tied to one insurance company. We always look at the client's needs and then match them to the available policies on the market. There's no cost to our services. We're compensated by the insurance companies, and that compensation has no impact on your client's premium. So if a policy costs $100 or $20, that's the same cost through us or through the company. The benefit they get is that they get us. And as this subject matter today will kind of indicate, I believe the best value we bring after enrollment is to make sure that they renew every year, because there's always changes, as you'll hear in Medicare, and it's important that we stay on top of them. So that lifetime support is a big part.
I love it. Now, I don't want to put you on the spot, but I always like when I have somebody on one of these discussions, it's sort of like, share with us something a little bit about yourself that we know you as the Medicare expert, but what's something interesting, the little glimpse behind the world of John Norce?
Oh, you're very kind, Steve. I've been a resident of Virginia since 1984. I went to college at University of Richmond, moved up to Northern Virginia after graduation. I am not married, but I have a nice girlfriend the last 18 years. I am very active physically. I love to do outdoor activities. I hike, I coach baseball, I play golf when I can. I just kind of enjoy anything that involves the sun. I've been a wish granter with Make-A-Wish. I give back to the community as much as I can. And the same thing with Medicare Portal. We believe in serving our local communities.
I love it.
Okay, I appreciate that.
I think you can see on the screen there, we've got these discussions, we have a real diverse audience here today. As you can see, most of the people in the audience are here because they're looking for something for themselves. But we've got a percentage that are looking for a loved one, and we always have a large percentage of providers that are out there. So we hope to answer all of your questions, no matter why you're here. And I'm going to duck behind the curtain now, but I just want to remind you, at any point in the discussion, you can ask John a question and just type it in using Q&A or raise your hand, and we'll do our best to call on you. So John, take it away. And if you want to just check in with me periodically, I can let you know if any good questions come.
That sounds perfect. So regarding this presentation today, this is what's known as an educational presentation. I will not discuss any plans or changes to specific plans or benefits within specific plans. This is kind of a high level to help you understand exactly what the annual enrollment is, the importance of it, and then how it can impact whether it's you or your clients, depending on, or a family member, because it is important that you know exactly what you can do and when you can do it. So today I'm going to cover these 6 topics here. As you can see, what is AEP, as we call it? Some people call it the fall open enrollment. What changes can you make each year? When can you, or where can you find these changes? I'm going to tell you where you can look for them if you, for some reason, feel like you might have missed something. What benefit changes you can make. This is always an important one. I think sometimes we get calls from people that aren't sure if they can change their plan. We can explain to you what those changes that Medicare allows you to make. I will cover the actual changes at a kind of a higher level, but important changes that we see for 2022. And then finally, how our agency helps people here and throughout the country with their Medicare. So what is AEP, or annual enrollment? Again, this is a set time every year where you can do the following. You can join a plan, you can switch a plan, or you can drop a Medicare Part C or D plan. For those that may be saying, well, why is Medigap not here? Medigap is technically not part, or Medicare supplement is technically not part of Medicare. So you can change a supplement any time of the year. I won't go deep into that here, but the point being, Medicare open enrollment is for changes most commonly through your Part C Medicare Advantage or Part D standalone prescription drug plan. What are the dates of the annual enrollment period? So AEP technically starts on October 15th and ends on December 7th. However, we are in what's called pre-AEP right now, which technically starts on the 1st of October, where we're able to engage our clients and start to prepare them for any potential changes that they might seek to make during that window. We are prohibited as agents to submit applications for changes anytime prior to the 15th. So the 15th is an important date. If you do want to make a change and you want to do it on your own, you could contact your insurance providers on the 15th and all the way up till December 7th. And any change that you make, as you see on the second sentence here, becomes January 1st of next year. So whether you turned in your application on the 15th or the 7th, assuming it gets in properly, your change request would go in as of January 1st start date. And last thing is, you could make multiple changes during the open enrollment period, but ultimately the last one that's on record when December 7th strikes would be the plan that you would start next year. I don't advocate submitting, 5 applications, but if you are confused or did something that you regret, you do have the ability to change that during the open enrollment. So what changes should you look for? So as a current Medicare beneficiary, you're going to want to look for changes in Medicare Parts A, B, C, and D, as I indicated. And these are going to be things that you're going to want to pay attention to, whether it's a change in benefits, whether a benefit was added, removed, or modified. Premiums. I can just tell you that premiums change year over year in a lot of parts of Medicare. Most commonly, you'll see the communications in November about Medicare, which I'll talk about later. But Medicare Part B, for example, will have premium changes, deductible changes, and things like that. Co-payments. If you have a plan C or D, oftentimes your co-pays for various services will change year over year, as well as deductibles. Just in the last 3 years, I can tell you the Part D deductible for prescription drugs went from 435 to 445 to next year 480. So that's one example of how deductibles can change. Plan specific changes, again, within your plan, you could see a change in the formulary, meaning the drugs that are covered for your specific plan typically will change year over year, as well as drug tiers, which the tier is there's 5 tiers. If your drug was a tier 1 and next year moves to a tier 2, you may not see a big change in cost, but if your drug went to a tier 3, for example, you may see an increase in your cost. You want to pay attention to that. Network providers, as we know, a lot of Medicare Plan C are developed with an HMO or a PPO or a point of service, an in-network aspect. You want to make sure that your doctor or plan providers will remain in network for the upcoming year. And then finally, service areas. Medicare is built around service areas. So if there's a change in a service area, it could impact your eligibility for that plan. So how are you notified about these changes? So we know this term. A lot of people may not know this term common, but we call it an ANOC, or your annual notice of change or annual notice of changes. And as you can see here, it says your annual notice of change is a summary that includes any changes in coverage, cost, or service area that will become effective in January of the upcoming year. So as I indicated, all your focus right now, any changes you make will be deferred till January 1st of next year to start. So between September 15th and September 30th, you should have been mailed your annual notice of change from either your standalone Part D provider or your Medicare Advantage provider. Those, depending on your situation, you should have received something that would notify you of changes to their plan for the upcoming year. And the reason that that happens is because then you have ample time to prepare for the open enrollment on October 15th, so that if you have to make a change, you can. So for example, every year there seems to be a plan that leaves the market for whatever reason. It could be a prescription drug plan, could be a Medicare Advantage plan. In September, they would tell you that your plan will not be available on January 1st of next year. And therefore, by telling you that, you have the responsibility to enroll in any plan that would be in your service area for the next year at your discretion, whatever plan you chose. So that would be a very important one, because technically, if you didn't act on your plan leaving the market by December 7th, you could put yourself in a situation where you do not have those benefits at all. So that ANOC is an extremely important part of your Medicare renewals year after year. If you haven't received it, you can call your insurance company that's providing you those benefits, or you can contact our office, as we have many of those available on a generic PDF that we can just get out to you as well. We're glad to help any way we can. So on the ANOC, the changes you can look for, and I mentioned this early, would be a notification of a deductible change. So if you had a Plan C Medicare Advantage plan, they may notify you that you have an in-network deductible of X, or an added network deductible of X, or your Part D plan. Many plans have a 0 deductible. Some have the 480 coming up for next year, and some have plans in between, or deductibles in between that. Knowing that change is important, because if, in a sense, if it goes up, you could be exposed to additional costs for the next year. Premiums change. Part B, as you'll see later, will change for 2022. Part C premiums can change year over year. And Part D, we see more changes in D than C. This is a typo, I apologize here. Medigap shouldn't be on there, but your Medigap premiums, a lot of people renew those or review those this time of year because they think that it's tied to the open enrollment. But you want to pay attention to Medigap premiums just in general, and understand that you can make those changes to Medigap anytime during the plan year. You could be subject to medical underwriting for that. Medicare's Part A, B, and C, and D have no medical underwriting. You qualify for any change regardless of your health condition. With Medigap, you would have to go through underwriting. Copays, oftentimes you'll see a modification in copays. You could see a copay change for access to your doctors. Could be a change in diagnostic tests, hospital copays. You just want to pay attention to those. Co-insurance, as many know here, the difference between a copay and co-insurance is a percentage. So you want to pay attention to seeing if a co-insurance went from 0 to 10 or 0 to 20 or from 20 to 10 or 20 to 30. You just want to pay attention to that. And then your max out of pocket, this really applies to Part C Medicare Advantage. You want to know what you would be exposed to in the event you had a catastrophic situation or something that just required you to have a higher medical utilization than normal. You would want to know what your maximum out of pocket is. And many times we see a growth today in the PPO plans, and there could be one max out of pocket for in-network and then a second higher one that would combine the in-network to create a higher total out of pocket max if you sought services outside of the network on a PPO, for example. Just things that you want to pay attention to. Steve, I'll hit the brakes here for a second. Any questions that you want me to address?
Well, let's see. I'm not sure if you're going to address this later, but let me read it to you. It's from Charles Clark, and he says, Advantage programs are being advertised as the best plan. What are the positives and negatives of the regular supplement and Advantage plans? Confusion is caused by all the TV advertising and not the total truth is often told.
Yeah. Let me save that for a minute because I think some of that will come to light here in a minute. I don't have a problem addressing that unbiasedly, but I'm going to answer some of that right here.
Okay, that's
and
what
then
I thought.
I'll probably finish that answer here in a couple minutes.
Great, but to folks, if you've got a question, drop it in there, or we can answer them for you when we sort of open things up as well. But keep on going, John.
Yeah, no problem. So, what we've done previous to this is kind of helped you understand how the changes would be communicated to you, what changes that you can be on the lookout for if you are impacted by a change. What I'm going to tell you now, these are the changes you're allowed to do during the open enrollment period, the annual enrollment. So these are all compliant. You're able to make this change. Again, no one can stop you from doing this. It's important that you understand what changes you could make should your, for example, prescription drug costs have gone up during the year, or your medical costs gone up during the year, or you got a notification again that your premium is going to jump significantly or something. So there's 6 changes that you can make to your Medicare benefits during that October 15th to December 7th annual enrollment period. So if you have a Plan C Medicare Advantage currently, you can change to another Plan C, whether it's within the same company. So some companies have HMOs and PPOs. You like the company, but you don't want to be on an HMO, you want to be on their PPO, you can make that change. If you're with one company and you don't, your doctor left their network, the plan left the area, whatever your reason is, you don't have to have a reason to justify your change. You just want to make a change, you could change to another company's Medicare Advantage plan. So that C to C, as we call it, is one change that you can make. You also, if you're on original Medicare, so kind of tying in that previous question about what's best, I can't answer what best, but I'm just going to explain the change here, and then we'll talk about why someone might want to do that. If you're on Medicare A and B, and whether you have a secondary supplement or not, and you have a prescription drug plan, you can enroll in Medicare Advantage. So I could put in an application on the 15th, and on January 1st, I would be enrolled in a Medicare Advantage plan. So we call that original Medicare because A and B is your primary payer currently, and then you'd move to a Plan C starting in January. You also can go from a Plan C back to original Medicare. So if you had a Plan C that you, for whatever reason, weren't happy with, or you felt it wasn't delivering you the care or benefits that you wanted or needed per se, you can make that change back to original Medicare, which would be A and B. We would recommend, if you didn't have it, you would acquire a Part D drug plan, because failure to do so would put you in a situation of a penalty. And then you would be able to explore a Medigap Medicare supplement plan as a secondary payer to that. That would be the third option. The fourth option, which we see the most change in is a simple Part D to another Part D. So this is where you have original Medicare A and B, and more than likely you have a Medicare supplement. you have to buy a Part D, what we call standalone, because the A and B and the supplement do not provide your Part D benefits. And this is where we see the most activity because of what I alluded to earlier: deductible changes, tier changes, premium changes, consolidation, plans leaving the area. So this is an important part. We typically focus a lot of our effort as an agency on our clients' Part D benefits, whether they're in a C or a D, but we find the most work we do where we are getting involved with our clients is reviewing the Part D standalone and making sure it's the right plan for the next year. The fifth change is initial enrollment in Part D. So occasionally people forget that they need to enroll in Part D when they're first eligible. To kind of make a generalization, through the years I've done this, it's a person who doesn't take any medications and doesn't see the need to enroll, which again is fine in their rationale. Unfortunately, the government doesn't see it that way. So if that person waited 1 year or 2 years or 3 years to finally enroll in Part D, they will face a penalty. However, that penalty would be, the amount of penalty would be terminated at a certain level starting in January next year. So just for an illustration, if they missed exactly 12 months, they would be a 12% penalty that they would pay to the federal government. But by enrolling in January, it wouldn't be higher than 12. Hypothetically, if they waited another year, it could go to 24%. This isn't really the reason, or I don't want to get into weeds on it, but I just want to understand that that is a situation that we occasionally are brought to our attention when someone doesn't have Part D. And then the other option is that if someone has Part D and for whatever reason wants to opt out, which they have every right to do, this is also the time that they would want to do that. So those are the 6 changes. Again, we see the most activity in the first 4. The last 2 are kind of unique circumstances, but obviously we can help them, and there is obviously resources for those individuals to do the same during the annual enrollment period. What I want to get into here is just, I mentioned earlier, I'll talk about changes to give everyone here an idea of how much Medicare changes. I haven't officially confirmed that the premium is $158.50 for next year for Part B. I can tell you 100% it's $148.50 for this year. Again, what I read, what I'm told, it's $158.50, but that would be the new premium that everyone has to pay as a base premium. There is what's called IRMA. If you skip down to the 3rd line, that's if you make over those amounts as an individual, 88 or 176, or next year 91 or 182. If you make over that amount, you would pay an additional premium on top of the $158.50 using that. The Part B deductible is an important number to know because most Medicaps issued today, unless you're age eligible, are Plan G as in girl, or G or N or high deductible G. All those plans under a ruling by by the government, you have to pay your Part B deductible before those plans will kick into benefits. So this year it's $203, next year it's $217. So to make that clear, if you have a Medicare Supplement Plan G, which is very popular, you have to pay the first $203 this year, and then resetting in January of next year, you would pay, again, we're estimating it to be $217. For those on this call that may have older family members or people they care for, Plan F, as in Frank, used to be the plan that was enrolled most popularly because that took away your responsibility to have to pay that Part B deductible. Plan F is not available for new enrollees unless you had Part A or were born before January 1st, 2020. As I mentioned earlier, the Part D deductible is going to go from $445 to $480. That doesn't mean your plan will go to $480. That means that your plan can go as high as $480. Again, there are plans that have 0 deductible, then there are plans that are going to have $480, and then there's everything in between, so to say. You can do that research, or we can do it for you to find the right fit. I list the Part C premium here for Medicare Advantage. This is a nationwide average premium. Again, this is reported by CMS. This year it's $21.22. Next year it's going to go down a few dollars to $19. The average Part D premium, we always put this out there so people understand when they're new to Medicare, especially what the average cost for their premium would be. You see it's going to go up slightly. What I can say is the gentleman that was asking about the ads on TV for Medicare Advantage, Yes, many of those plans advertise as zero, but that doesn't mean that all plans are zero. It just is one benefit of some of the plans that they make it a zero premium, clearly for a competitive perspective for customer acquisition or retaining customers. The fact that it costs zero each month clearly could be obviously financially something that people can afford, but also maybe something that would keep them on the plan because they're, in their mind, they're not paying any premiums. As far as trends in Medicare, I just pulled some things again from Medicare that are current. So just responding to the question on Medicare Advantage again, in a sense, right now it's 26.9 million estimated that are enrolled in an actual Plan C. After this open enrollment period, it's expected to reach 29.5 million. I don't know the exact percentage of that. That's why I didn't list it, but it would be higher than 42%. There's a little over 60 million Americans that are eligible for Medicare today. The number of Medicare Advantage dual special needs plans, these are the Medicare and Medicaid. Many of you here may help customer or clients with this, or have family members or friends, or you might be. The dual special needs plans, which is where you have Medicare and Medicaid, will increase. So from 256 to 295. There's a typo there again. I apologize. CMS, that's Center for Medicare Services, not CMA, will continue to test the Part D insulin senior savings model. What we mean by that is last year it was incorporated that they capped a copay of $35 for insulin each month. They're going to continue to do that. Obviously, that's a wonderful benefit for those on insulin because of the, unfortunately, the escalation in the cost of insulin. This is a way to kind of curb it because sadly, these people need it every day, and money obviously was preventing some of those people from staying healthy. So to resolve it, they have the insulin savings program. You just want to make sure if they're moving to a Part D plan that their new plan has it. And if their current plan doesn't have it, to identify that their new plan has it, should this be something they need. People with end-stage renal disease can enroll in a Medicare Advantage plan. I point this out because historically, up until actually this year, January this year, someone who had ESRD could only enroll in a Medigap plan. Now they're able to choose Medicare Advantage. Again, not trying to entice people to move there, but Medicare Advantage plans would, in a sense, help that person who may need dental or vision care or some other outside services that weren't available under their Medigap and original Medicare. It may give them leverage to get those benefits and may make sense to them. Lastly, more than 1,000 plans will participate in this long description, but basically the program is their special needs plans. So in many of the states, you're seeing these special needs plans. For example, you might have a diabetic special needs plan. It's a Medicare Advantage plan that's designed to help those individuals care for diabetes in a more laser focused way, building the benefits, access to care all under one coordinated plan. You'll see them for cardiovascular. Sometimes there'll be a cardiovascular program. We're seeing more and more of this because it looks like there is data that proves that these individuals are better able to manage these chronic conditions, not only from a health perspective, but from a cost perspective. So these are some of the trends I thought might be interesting to those on this call. I will highlight quickly what we do. Again, we are available at no cost. We will help you understand your ANOC. So if you received an ANOC and you're not sure, we can help you explain that to you. If you need an ANOC, let us know. We can help facilitate that. We do a no-cost review. We're never any cost to you, so you can call us for any service. We cannot charge you. We can confirm if you're on a Medicare Advantage plan that your providers stay in network. We can present options for you if you're unhappy with a plan or your plan is leaving the market and you need to make a change. We can help you research your options. And that, ultimately, no matter what we do, we always want to make sure if you work with us that any plan that you're enrolled in or will be enrolling in will meet your financial budgets and medical needs for the upcoming year. Those are always what's most important to us as a company. We truly do care about the communities we work in. Before I take questions, Steve, I just wanted the question about Medicare Advantage. When I say it's a loaded question, I think if you asked 100 people, you get 100 different answers. but it truly comes down to a personal decision. We always approach it from how you've historically received care. I always put care first is how you should continue. And what I mean by that, if you're an individual that always chose all your providers with no referrals, and you traveled and you just felt like you didn't want anyone confining your access to providers in any way, then original Medicare A and B with a supplement would typically be the solution that those individuals would check or choose because it works for them. There are today PPO plans that do that same thing where there's an in-network benefit. They do offer you access to Medicare providers, albeit at a higher cost, but you still can resolve that. We typically would never lead a client into a situation where enrollment into a plan was because of a dental benefit or a vision benefit. We always want to make sure that medically speaking, that's what we focus on. So that would be the doctors being in network, the prescriptions being on the formularies, and then making sure that obviously the costs within the plan are fit their budgets and needs. TV, sadly, I agree with you. These ads as an agent who's compliant, who has to deal with compliance all the time, I scratch my head when I see them because I wonder sometimes if those are compliant ads or not. But I would tell you it's a personal decision. You have plenty of time to evaluate your options. One thing to point out real quick, if you do enroll in Medicare Advantage for the first time during this open enrollment period, and you had original Medicare, say with a supplement and Part D, you get what's called a 1-year trial right, where you try the Medicare Advantage plan. And for whatever reason, during that next 12 months, if you're unhappy with the Medicare Advantage plan, you can revert back to your Medicare A and B with your supplement and a prescription plan and face no penalties of any kind. If you stay beyond that 1 year, you still could revert back to A and B with a prescription plan during the open enrollment. The challenge there would be qualifying for that Medigap plan, because after you leave your true open enrollment of Medicare, which is 6 months from your initial enrollment, and that 1-year trial right, you do then face potential underwriting. Now, I made that general statement. There are some states that don't have Medicare medical underwriting for supplements, but for time and confusion, I'll just hold off on that list. But with that, Steve, I can take questions.
Oh, yeah. And we got a pile of them for you here. Doesn't surprise me. So, okay. So we answered Charles Clark's question about Medicare Advantage. Okay. Pauline says, thanks for the presentation. Will you explain coinsurance?
Sure. So Medicare Part B, for example, very simply, after the Part B deductible, whether it's the 203 this year or the 217 next year, you would be exposed to 20% of those claims, 80% by Medicare, approximately 80%. 20% would be your exposure. So if it was a $10,000 claim, just assuming we've paid that Part B deductible, an insured under original Medicare would be responsible for $2,000 of that $10,000. How you address that if you enrolled in a Medigap, for example, it would address that 20% payment for you, leaving you really with basically no, assuming they're all Medicare approved expenses, really with no financial exposure to any additional costs. You'd also see coinsurance sometimes in Medicare Advantage plans for things like durable medical equipment, could be under Part B chemotherapy drugs. They'll charge you a 20% copay, or coinsurance. So that's how coinsurance works. Copay is a fixed dollar amount, $10 for a doctor, $20 for a specialist, $15 for diagnostic labs, $20 for PT. That's a copayment, a fixed dollar amount.
Great. All right. Cedar says, if your client has a problem or denial of service or a prescription with their Part D or C plan, do you help them with an appeal or an exception?
Sure. So for us to do any services, we would have to be your agent of record. We cannot really, I could have a high level conversation of what the procedures might be, but we would help all of our clients with what's called an appeal or grievance. But unfortunately, I can't help someone who's not a client. That's CMS guidelines. Again, we can help coach you in terms of answering basic questions about procedures, give you phone numbers. But unfortunately, unless someone's a client of ours, we cannot get involved with that situation.
Oh, and I've talked to a lot of providers that have worked with you, who had clients that were in a bind, and you did a really good job of coaching them through. Let's see. Charles Clark says, when you change from a supplement to an advantage, or from an advantage back to a supplement, will you have to get an underwriter's approval, which may cause a higher cost due to pre-existing conditions?
So Medicare Advantage has no underwriting. So if you moved to a Medicare Advantage plan at any time, you would not have a rate reflective of your individual health. That rate in your area, whatever it's quoted to the public, whether it's $0, $10, $20 a month, would be the same regardless of your health. When you apply for a Medigap plan, after that first 6 months of open enrollment, you get, whether it was turning 65 or after a special enrollment period that you work past 65, the Medicare supplement providers can invoke underwriting at that point. And it could be anywhere from issued with no rating to issued with an additional cost rating, or they could deny you enrollment. Again, I can't speak for all those scenarios, but those are all real and are possible. That's just the nature of the Medicare supplement industry, so to say.
Okay. And let's see. A question from Ed Miller says, are FEHB plans considered Part C plans, Medicare Advantage? What is FEHB?
So Federal Employee Health Benefits, as this Mr. Miller knows, is a benefit plan provided for federal employees. What I can tell you is, well, OPM would be the ultimate to answer everything, but FEHB does offer today Medicare Advantage plans that you would need Parts A and B to enroll in. They also offer just what I would say traditional or employee-driven plans that are outside of Medicare Advantage. The difference being in FEHB, if you wanted Medicare Advantage today and you didn't have Part B, you would have to get Part B to enroll in a federal Medicare Advantage plan. That's just the difference there. So I can just tell you from just what little knowledge I have, like Kaiser is a Medicare Advantage provider in general. They are only a Part C provider, and their plans are available, I know, within FEHB. So that would be an example of a Part C, but also I know they offer a plan that's not a Medicare Plan C. So again, I would consult with OPM on any of that. But that, I hope I answered your question accurately.
Yeah, and also, folks, I pasted John's contact information into chat. I'm going to do it again, just in case anything you need more elaboration. John's great to reach out to get info on that. So Robin Hall, first off, she wants, can you restate the meaning of ANOC, ANOC?
Let me go back. I see Robin Hall had asked a question about Part F.
Yep.
So Ms. Hall, so Plan F, if you have it, you are able to stay on it. They cannot take you off of it, and nor should you let anybody tell you to leave that plan. By every right, you were enrolled in it prior to January 1st of 2020. The government, Medicare, decided that they no longer wanted to have 100% paid plan, which in theory Plan F does, because it pays the Part B deductible and then the 20% of Part B. They went to Plan G, girl, so that they pass through that Part B deductible, so it's no longer 100% plan. So your Plan F does cover that Part B deductible. So whether it's 203 this year or 217 next year, you would never be billed for that Part B deductible. Where if just someone like you switched to Plan G, or your friend had Plan G, that individual would then be exposed to that deductible. That's the only change. But I want to make it clear that do not leave your plan if you like it and it works for you. Do not let anybody entice you through a phone call that you should change. And say it's important that you know this.
Okay. And Robin Hall, the same person that asked that question, just wanted you to restate.
ANOC, yeah. Annual notice of changes or change. And the simple thing is, if you have a Medigap, you probably have a standalone prescription drug plan, Part D, and you would have received an ANOC for Part D. There is no ANOC for Medigap technically. There's just not.
Robin says thanks.
Yep, no problem.
And let me jump over to chat because I'm trying to go in order of these coming in. But actually, it's a good question. from my friend Louis Tenenbaum, who is a universal design expert. He says, this is good, but it is so clear that the whole thing, what are all these parts and how they relate, is frankly absurd. He asks, do you see more Advantage plans offering home safety assessment through supplemental benefits or SSBCI? Yeah, so
Yeah,
there's benefits.
that's when I say a hard question, I don't, that's not I mean, it's a conversation we occasionally have with clients. I just, yeah, I don't feel in a position that I can answer that with a definitive. I don't have those numbers and trends. What I can tell you is that Medicare Advantage, the reason it does things like dental, vision, gym memberships, hearing, is because they want to keep you healthy. So if I know the big one in star ratings, for those of you that are familiar with star ratings in Medicare, one of the big ones that'll ding your star rating is clearly hospital readmission. So if they can keep people recovering and not being readmitted for the same conditions, I know that that's something that all insurance companies look at, because clearly that's not only cost, but also negatively impacts them on star ratings. So are more companies being in touch with home health care? Well, Part A and Part B, as many on this know, covers a lot of the home health services. Medically, it's the custodial part that Medicare is not involved with at all. So activities of daily living are not being covered as a standard benefit under Medicare. So that's where it kind of gets.
Yeah, I think I know that he's a real advocate for doing things to remodel our homes to make them safer. And based on the way you just described that, it seems like that could be a real possibility for.
Yeah, that's going to be covered more historically under long-term care benefits. Home modification was something always addressed under that long-term care policy, not Medicare. I don't want to get in the weeds, but that's where I would direct that question towards. As of today, I don't know of a standard benefit for grab bars, say, under Medicare.
Okay. Got it. No, that's great. Okay, let's see here. Let me do one more from chat from Carolyn Warren, who says, I'm covered under the federal government health program. Should I consider a Medicare Advantage plan?
Yeah, I can't. That's a personal decision. I would say that to do your research, kind of the process that we go through is to match your plan you're considering to make sure they have your providers, and then also match up that they can cover your medications. And then I would do the research to find out if the other benefits and how the plan would give you future care if something happened where you had a complicated condition or traveled or whatever it might be. I think there's a very global look that you need to start with. And then once you kind of narrow down your options, if it's still a viable option, kind of get more in the weeds to see if it's an option for you. Again, OPM would tell you on how it would work. I can tell you need Part B to enroll in Medicare Advantage, but I'm sure under the Medicare or the insurance program under FEHB, there is a way to change every year during your open enrollment. But I would direct a lot of that to OPM, and then it's a personal decision. I really would bring it down to that.
Let me ask you, for those federal employees that are out there that might have a similar question as Carolyn, do some of the federal employees that you work with choose to go that path is that something that people evaluate and they're like, oh, I think Medicare Advantage might be better?
Well, yeah, one thing was that I would just say, as of many years ago, and OPM would probably know the date of it, there were no Medicare Advantage plans available through FEHB. In the last couple of years, the insurance companies have offered these Medicare Advantage plans as an alternative for people over the age of 65, not forcing them to be on health insurance, as I call it. And one of the things, just for those that are considering in general your benefits, FEHB or other employer type benefits, Medicare is built for an aging population. So Medicare, for example, is going to have outpatient rehab, nursing home, hospice. It's going to have things designed, durable medical equipment, where you have to check if your current health plan would have those benefits available to you. that may be something to consider or look at when you're deciding, should I stay on health insurance or consider a Medicare Advantage plan? Now, one option that is available to FEHB is that if they have parts A and B, and they, again, you can work with OPM on this. This is one of your options, that you can suspend your federal employee health benefits, meaning that you just disenroll from it to enroll in a private Medicare Advantage plan, not a government Medicare Advantage plan, but you can enroll in a private Medicare Advantage plan for the year or 2 years, whatever it takes. And in the future, you can then reactivate your FEHB because you suspended it. You didn't cancel it. You do not want to be on FEHB, suspend it, and then go on a Medigap plan. You can only go on Medicare Advantage if you suspend FEHB. I'm not trying to entice you to call me to say that that's the change you want, but that's an available change to you. That it's available. I'm not advocating you do it, but I just want to educate.
And then I'm gonna jump back to our list of questions. We still got a pile of them here, but Krista Kramer says, what is the status of coverage for hearing aids?
So under the federal Medicare program, there is no financial benefit to cover any of the hearing aid costs. If you enroll in Medicare Advantage, there's a number of plans available. Many of those will offer a financial help scenario where it could be a copay, a fixed dollar amount, to where they help you purchase those. And again, those are going to be typically from specific providers. There's going to be a relationship that's going to force you, in a sense, to buy from one provider or just a warehouse of a few providers, because they have a negotiated price to help bring those costs down.
Okay.
But original Medicare will not help you with hearing aids.
No, that's great to know. Okay, so now back to our questions here. And you may have had a slide, I think, that cited this one, is how does income affect Part B premiums? What is the possible maximum premium?
Yeah, so for this year, it's 507 if you make over $500,000 as an individual, or 750 as a household. So the 148 would be included in that. So that's the adjustment up that you would pay. There's also a Part D, what's called IRMA. So if your income goes above those levels as well, you would pay an adjustment. This year it's 77. I think all in, if you are in the highest income bracket, it's like $585 and some pennies combined for IRMA Part B and D. That you can find that on the Medicare website. If you can't, we'll send it to you. That's public information. Glad to do that. Just contact me and I can help you with that. No problem.
Okay, great. And let's see, a few questions about your PowerPoints. Would you be able to email me those?
Yep, I'll get it to you right after the event,
Okay.
Steve. No problem.
And for a couple of those questions, for some people that got in late, just to let you know, Bernadette and some others, we are recording this, and so we'll post the recording this afternoon along with John's PowerPoint. In addition, we record this as a podcast, so somebody could listen to it while they're walking their dog. Let's see. What is the difference between an Advantage plan and enrolling in a supplement?
Yep. So the difference there is who's the primary payer. So the easiest way for me to explain it is, if you get A and B as your primary payer and then buy a supplement, that's the one option you have, because the government is a first payer and a supplement is a second payer. When you enroll in Medicare Advantage, the Medicare Advantage plan, whatever the name, doesn't matter, takes over that primary payer slot. So if you enroll in a plan C, you no longer could submit claims to A and B, because all those claims, in a sense, are coordinated through your new health plan, whether it's a HMO, a PPO, a point of service, was known as a PFFS. It doesn't matter. Now that plan is your primary payer. And here's how that happens behind the scenes. When you pay your premiums to the federal government for Part B, if you stay with the original Medicare A and B, they keep your money because they're paying your claims. When you enroll in a Medicare Advantage plan C, the government actually takes your money and sends it to that Medicare Advantage plan to have them responsible to pay your claims. So that's why you're unable to file claims under A and B when you enroll in Medicare Advantage. Medicare Advantage, as we call it, quote, replaces your Medicare A and B benefits.
Great. Okay, is Medigap the same as supplemental?
Yeah, I use those intermittently. I apologize if it's not meant for confusion. I do it because of this question. They're both the same thing. Medigap, Medicare Supplement are the exact same product.
Okay, and let's see. Somebody says thank you for being willing to teach and educate about sometimes complicated and confusing health insurance.
Not a problem.
So Medigap supplement plans have insurance underwriting and can be qualified for pre-existing conditions. This is complicated.
Yeah, so just quickly, when you do your initial enrollment in Medigap, so your Part A and B recently became active, you have 6 months from the time they start. You obviously could apply before that to start when you first start Medicare, but that there's no medical underwriting. So if someone's turning 65 and they want Medigap, let's just use November 1st, they're turning 65. They can enroll, assuming they have the A and B right now, start on November 1st with no medical underwriting. They could be in the hospital. They could be running cross-country races, is super healthy, and anything in between. That person starts in November with no medical underwriting. 6 months from now, that individual decides, or 7 months from now, that individual decides they no longer like the Medigap they're on. They want to change. They would have to go through underwriting. If they are just staying where they are, they just want to change their plan. And at that point, they can invoke, like I said, a decline, a rate up, or they could qualify for whatever rate was quoted to them. And then the same thing applies if you work past 65. Whenever you elect for A and B, you get that same 6 month window where you have no medical underwriting.
Great. Okay. I just looked at the clock. It's 4 minutes to 1. I know some of you will jump off at 1. We're going to keep recording. John, are you cool? Hanging
Always.
tight?
Absolutely.
Okay. Yeah, let's get through these questions because they're really good. Let's see. Can you discuss the enrollment rules for individuals who have employer coverage for themselves and their spouses, and how to proceed beginning age 64? I think this is a very common question.
Yeah, right. This has nothing to do with AEP. So this is, and we do a webinar on working past 65. If you go to our website, medicareportal.org, there's an events tab that you can see. Every month we do 4 standard educational events. This time of year we had an AEP one. But the point is, we typically, if you are in a situation where your employer is under 20 people, the government will become the primary payer of claims, and your enrollment in Medicare A and B is required because the insurance company will recognize that your employer is under 20, Medicare is primary, so enrollment in Medicare A and B would be required. If your employer is over 20, you work for what they call a large employer, you would not have to do anything at that point because their coverage is considered creditable, meaning it meets or exceeds the Medicare standards, and therefore you can delay your enrollment into Medicare till such date in the future. We always recommend starting at least 90 days prior to a Medicare event. So if you knew today, I'm just going to give a very standard thing that we're working on is that people are retiring on December 31st and looking to start Medicare on the 1st of January. We're starting to help them with their A and B application and getting them set up with that, and then doing the supplemental benefits, secondary and all that. So this is the perfect window to do that. So we're not rushed. And if things take longer to process at the government, we have plenty of time to do that. If a spouse is older, turning 65, you have a spouse under 65, and you have to go on Medicare, and it's a small employer and your spouse doesn't have, that's complicated, but that's what the Affordable Care Act provides, the healthcare.gov. You have COBRA as an option for that person under 65. So again, it's confusing. If you want to have a conversation, which we do, just call us and we can get deeper into your specific situation.
Great. Renee says, we'll be eligible for Medicare in February. Plan to continue to work. Can you confirm I just need to enroll in the basic Medicare? Don't need a supplemental policy. Will continue to have insurance with my current employer.
Yeah, this is what I just said, that over or under 20. If it's over 20, she can 100% delay, no issue. If it's under 20, again, you have to consider enrollment in Medicare because that would be your primary payer of claims. Part A, if you are going to work past 65 and you work for a large employer staying on their plan, you would not NOT want Part A, because if you enrolled in that and you're funding a health savings account, an HSA, you cannot do that. So if you're on just regular health insurance, when you turn 65, you have some PPO with whatever, you can enroll in Medicare Part A as a secondary payer. It doesn't cost you anything to do Part A in that situation. But if you are funding a high deductible health plan with an HSA account and enroll in Part A, all your contributions would be negated and you could face tax penalties and things like that. That's the best quick advice I can give you.
Great. Okay, next question relates to snowbirds, people that live in the north and move to southern states. If there's a secondary insurance is Medicaid, if the secondary insurance is Medicaid for your state, do you need a supplement, a Medigap policy plan to cover the 20% while you are in the southern states with your Medicare original coverage for the first 80%?
Yeah, so this is a dual, I'm assuming this is a dual person, meaning they have Medicare and Medicaid, and I'm just going to use the state of Virginia. So in the state of Virginia, you cannot have a supplement Medigap plan with Medicare and Medicaid. You would have what's called a dual, well, you can go with that or enroll in what's called a dual special needs plan. And that is basically the coordination of Medicare and Medicaid through an insurance company. So insurance company Gurney has a dual plan available, again, for example purposes, in the state of Virginia. By enrolling in that, they would have a network of doctors coordinate all your care. And some of those are PPO plans that allow you to go out of network. It's not that it's a loaded question. It's just a hard question to really answer specifically. But what I can tell you is Medicare's primary payer, Medicaid would be secondary payer. And then depending if you're on an HMO or a PPO would dictate any out-of-network benefits. Emergencies would cover it anywhere, but routine care on an HMO out-of-network, you're probably going to have a little bit of problem with that.
Okay. And then Robin says, and I think this relates to this. She says, I typically serve clients that have Medicare and Medicaid. What is the recommendation for the additional coverage for Medicaid clients B and D?
Yep. So this is the question around my trend in Medicare, where there was 256 plans and next year is 295 plans. That's where these large insurance companies or health plans are getting involved, where they're coordinating for that individual the Medicare and Medicaid benefits. And then they're layering on top of that sometimes dental, vision, hearing, transportation, what's called an over-the-counter benefit. They're trying to enhance their benefits and quality of life by offering them care, obviously at very low costs. It can be zero most times, access to additional funds to buy things for health reasons that they may not get. The dual plan would be the only thing that would, in a sense, leverage their benefits for something more. But again, research in your area, the plans that are available, that many are network driven. So you don't want to just go for benefits without provider participation and formularies and things like that. But again, that's a complicated conversation. If you want to reach out to me, I'm glad to have it with you. Not a problem. We're always glad to help anyone.
Great. And John, I'm going to read this next question and then I just got to run down the hall real quick, but you can, if you finish it, you can jump on the other questions. Stephanie says, for people in states you don't cover, how do you suggest people find a reputable company that offers similar services to yours?
Yeah, I mean, we work in 22. I just added another state, 23 states. We should be nationwide next year. But I do have I've been in insurance for 3 decades. I have a lot of friends throughout the country. So there's a chance if you want to reach out to me that if I can't help you or my team, that we can find somebody for you. If not, there are organizations like NAHU, the National Association of Health Underwriters. That is the National Health Insurance Agents Association. That's extremely reputable. It has some very high quality people that I would lead you to, find somebody that way. Yeah, telehealth. So telehealth is a new benefit as a result of COVID. Medicare covers it. And as a result of Medicare covering it, so does the Medicare Advantage plans. Most of what we see, again, I'm very general, is a zero copay for telehealth. So they've really tried to make it an enhancement to the plan's offering because of the adoption of telehealth, the convenience, the success of it during COVID. Again, find out from your providers, but again, that's a new enhancement to Medicare that we see as a positive.
All right. And so then Chuck
I
said,
could just read it right here. You want me to go in order? This is Chuck.
yeah, that's great.
And looking at a significant difference between advantage gap, it appears that advantage will cover an immediate hospital stay, but not if it goes longer to a longer stay or nursing care, but Medigap will. Kind of. Medicare Advantage is required to meet Medicare standards. So for example, a discharge from a hospital to a skilled nursing facility, you get 20 days at no cost under Part A Medicare, and you get the same 20 days at no cost under Medicare Advantage. No matter what plan you go on, I can tell you that for a fact. They have to meet Medicare standards. It's days 21 through 100 where you're going to want to pay attention. If the Medicare Advantage plan gives you no help on those, some could give partial help on that. But Medigap, if you enrolled in, say, a Plan G, would cover days 21 through 100 also at no cost to you. So the cost this year is $185.50. I don't know what it is exactly for next year, but that's a per day after day 21. So, again, that's a very accurate answer, but if it doesn't address your specific question, feel free to call me or email me. The book that you sent, we are surprised to see Medicare will cover an acupuncture. Yep. We have not had a chance to read details, but are you aware of new coverage for care offered original Medicare? Yeah, so telemedicine. So acupuncture has become a more popular benefit because they're trying to help people not go on pain meds like OxyContin. So they're encouraging acupuncture as an alternative method of care that, if successful, clearly, I believe, would have long-term benefits of not being dependent on a prescription drug for pain management. Because of the adoption by Medicare, many of the Medicare Advantage plans have also adopted, actually, they were previous to Medicare enhancement of acupuncture. Some might offer a limited number of visits, but there was a benefit for acupuncture. So I think that's something that will evolve. Again, I think that's a positive change. Anytime we can help people get healthier homeopathically versus medications. That's just personal opinion, but I think a lot of people would agree with that. It seems often surprise Medicare patients that a only stiff days are covered. No, I am not familiar with a SNF stay of more than 100 days where there's any benefit. Hospital stays are different. So true inpatient, if you read Medicare, there's up to 365 days when you go into your base benefits and the added days, and you buy a supplement, but even Advantage will extend it unlimited. I don't know of anything. If they have long-term care, that's what I would tell you to look into. I would research long-term care policies for that, but Medicare, as we have it today, won't give you or supplement anything beyond 100.
Right. Okay. Yeah. So the question was related to traditional Medicare does cover under 100 skilled,
like 21 through 100 days.
21 through 100. Yep. Okay, got it. And
so then, this question, yep. Again, I apologize if there's confusion, but if you're going on Medicare, whenever it is, the effective date of your Part B is what triggers that 6-month window. So if at 65 you're going on Medicare, because your Part B would start the first of your 65th birth month, you get 6 months. If you wait to 70 because you've worked, you would get 6 months from the time you enroll in Part B then to also get no medical underwriting on your Medigap.
Okay. All right.
And then I'm pretty sure if employee rolls in A and B, and she's correct. Cedar,
Cedar says, I'm pretty sure that if an employer enrolls in A and B, because it's a small employer, the guarantee issue period for Medigap will still expire after 6 months.
Yeah, I'll answer it this way, that some companies will honor an employer letter that they had health insurance as a secondary payer, and they could allow them to get in with no underwriting. I can't speak for companies specifically on this, but I can tell you that there are scenarios that could exist where that individual, if they stayed on employer coverage as a secondary, would create a guaranteed issue versus what's called open enrollment, a guaranteed issue scenario where they could potentially get on without underwriting. That is correct.
Woo! Wow. Again, I'm left with the same feeling the first time that I had you on one of these discussions is that we probably need to do this monthly because there's so many people out there with questions. And as you could see, they're all over the place. But the good thing is, folks, if you're listening to this now, or if you are listening to the recording, reach out to John. He and his team can be invaluable to give you some objective guidance and help you navigate what is very confusing. And I'm wondering when we're going to get to Medicare Z. It's probably right around the corner because I feel
let's
like
hope not.
Yeah.
But yeah.
But anyways, John, this is great. Send me the PowerPoint. I'll put it up on the recording and look forward to
we'll do more of these, Steve. They're fun. I enjoy it. I enjoy the interaction. Great people that attend these, and anything we can do to help, as you know. But we'll see you soon.
See you soon.
Okay, guy.